Good morning, ladies and gentlemen. It's a great pleasure of mine to be here today, and particularly important, of course, is the celebration of the 21st anniversary of the AASD, and I'm absolutely delighted to take part. 21 years do go away very quickly, but grateful to Ines and the faculty for maintaining such high caliber congresses, sessions over the years. And I'm sure there's been some great achievement in the messages that have been delivered successfully over that period of time. I'm here to talk about inflammation in type 2 diabetes. I will give you an overview of the topic. I did write a chapter in a book some time ago when I was younger, and it's wonderful to be able to update some of the information that I didn't have at the time of writing. So, of course, our biggest problem is the pandemic status of diabetes, and a lot of us are spending a lot of time trying to contain this, not very successfully, I have to say, because the mortality remains high. Comorbidities amongst our patients is at its peak, and of course quality of life is affected in those patients that have developed complications. And the biggest problem that we have is the cost, not only to prevent diabetes, but also to treat and also to deal with the complication rates. In terms of glycemic control, we are not there yet, and I think there's still a long way to go. But you can see here that, in fact, if you look at snapshot audits of our patients, then we are achieving round about 60% of these patients have got HbA1c uncontrollable, about 7%, and then developing countries are really not any much higher than the developed countries. If you look at the USA and European countries, their HbA1c of less than 7% is around about 50%, compared to developing countries of about 40%. And the complications are well known to yourselves. There are these traditional complications, and of dear to my heart is diabetic kidney disease, and some of you will be interested in the other complications in your specialties, but draw to your attention to the emerging complications such as cancer, which will be covered in the next lecture, infections, liver disease, functional disability, and cognitive dysfunction in some of the patients. And of course, there's also the psychosocial aspects of complications of diabetes. So quite a lot of problems for our patients. I agree that we have to focus on lowering glucose so that the patients do not develop complications. But I don't think lowering glucose is the answer on its own. We have to look beyond the trajectories, what is causing this progression from pre-diabetes, diabetes to complication, as we've already alluded to. And even though we can try to achieve good levels of glycemic control, we still get some patients that develop complications. And sadly, if we focus just on glucose, we know the impact on macrovascular disease is low, lower than it should be. And you can see this meta-analysis which looked at 11 randomized controlled trials that were published, about a year ago. This meta-analysis was published about a year ago, which compared to intensive glycemic control to standard care, and they found that there was no difference in the major cardiovascular disease events, i.e. macrovascular disease impact was of no significance. But however, the microcytokines that I've listed down here, in the end, we get reduction in glucose tolerance, reduction in insulin signaling, increase in insulin resistance, and beta cell dysfunction, and over time, a lot of these patients will develop complications because the inflammatory process has not actually been controlled or even inhibited. So it gives us the areas to focus on for our therapy strategy. And at the moment, we have, of course, already got a lot of agents that are helping in the management of type 2 diabetes. And you can see on here, we got a pointer. At various levels, initially, here we can look at our lifestyle modification by utilizing a GLP-1 receptor agonist, and then we've got areas that are transforming here. Okay.
Dr. Mick, you need 1 minute more?
2 minutes?
1 minute? 1 minute?
Yeah, sure.
Okay, 1 minute.
So we've got a lot of agents that we can use to control type 2 diabetes, and the guidelines have already been elaborated which agents we should be using. Traditionally metformin, but now we know those patients with high risk of cardiovascular disease, we should be going for other newer agents like SGLT2 and GLP-1 receptor agonists. And in fact, with the inflammatory process, it's essential that we remember that the trajectory of type 2 diabetes is starting in the pre-diabetes era, and there's a lot of inflammatory processes that are occurring during that period that we can also focus on to try and give agents that will deal with the inflammation for patients to reduce their risk of progressing to type 2 diabetes. And these are some of the studies that have been published using such strategies for anti-inflammatory treatment in people who have pre-diabetes, diabetes, before they develop complications. And I've listed here a lot of studies that have already been published, targeting interleukin-2, interleukin-1 and 1B, and also at all levels of the trajectory of type 2 diabetes. And this is the meta-analysis which actually has shown that such a strategy not only improves glycemic control, but also can influence the progression to complications. So thank you very much, ladies and gentlemen. Thank you for your attention.